Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. The Trust is pleased to once again partner with Drs. Margot Adams Larson and Sarah Smucker Barnwell to present these telehealth community chats. They've done a tremendous job with this series, and I know that I and our policyholders appreciate their expertise and the time and effort that goes into putting these together. Thank you, ladies.
Thank you so much, Dr. Martin. We appreciate your having us, and always we appreciate everyone who's joined us to have our telehealth community chat. Margot, it's great to see you.
Happy New Year. It is so great to see you as well, Sarah. I'm looking forward to our chat today.
Well, as we go on to the next slide, we'll start talking about some of those disclosures and conflicts of interest. Always, we like to mention that both Margot and I do engage in telehealth training outside of our role in these webinars. And you could say that we have a horse in the race of telehealth being successful. That being said, this is because we are unabashed telehealth enthusiasts. We are folks who have done this in our practice for many years and really believe in its importance for the public health, as well as for the safety and well-being of psychologists. Always, when you are giving a presentation on technology, something will go amiss with the technology. So we now include that in our disclosure statement, just to have Nostradamus-like predictions. I think if we go on to our next slide, we'll talk a little bit more about what it is we do together on these telehealth community chats.
Absolutely. We are planning regular check-ins. We used to be doing roughly monthly, but we might space them out a little bit more because we've got so many other awesome webinars coming out as well. This one is really focused on telepsychology, on really incorporating topics of practical guidance, clinical concerns, the regulatory environment, and ethical considerations with regards to all of that. We have had some tremendous questions come in over the many months that we've been doing this. We have a telehealth community at trustinsurance.com email address that you can send your questions in advance or even after the chat today. We compile those, we do a little research, we'll get back to you, or we'll bring them to the chat. So again, that's telehealth community at trustinsurance.com. And you can type your chats in the Q&A today, or excuse me, you can type your question in the Q&A today. We do scan those as we're going through, and our plan is to provide some prepared information because there's a lot of talk. Several questions have come in already. We've got some information for you, but we'll be going and answering some of those live as well today. So keep those questions coming in. We can go on to our next slide. Over the several times that we've done the chat, we've gathered some resources and some information. We put these on the resource slide, and new today, our folks are going to be dropping a link for that slide into the chat. So you can go ahead and pull that up if you'd like while we're talking, and you can have your access to that as well. Always after the chats, the whole slide deck will be somewhere available on the materials in your CE profile at the Trust as well. So you can access the materials there too. And on to the next slide. So I know a lot of folks are hopping on. I've been watching. I know we have a lot registered. I think it's that time of year, Sarah. We get a lot of folks like gung-ho. We had a little rest and respite over the holidays, and now we're into what is coming this year. So today we have some topics to talk about vaccinations because we've got those rolling out. Things to do for the new year, both practically and maybe with considerations for how laws may change over that time. We have diversity and inclusion considerations, and also some questions that have come in about disciplinary actions and things like that. So we've kind of got a few topics, and I know we're going to have some great questions today coming in. So Sarah, maybe we can just kind of jump right into this probably biggest discussion of vaccines, the rolling out We're excited about that. But that does bring up a lot of interesting questions and conundrums with regards to practice and what we have been doing and now what we might need to be doing. So,
absolutely. And a question I've received quite a bit, I wonder if you have too as well, Margot, and actually I saw it come through on the questions for today's chat is, where do psychologists fit, into the vaccination schedules? Because this is a state-by-state determination with some guidance by the CDC, the question that remains a question and dependent often on your jurisdiction. I know where I live in Washington, high priority has been given to first responders and anyone delivering direct clinical care. And so in that manner, if you're a psychologist in Washington, well, if you're someone doing an all telehealth practice, you're going to be a lower priority than if you're someone that's, say, in a hospital or in a direct clinical setting, still seeing clients face to face. So there's really a lot of variation regarding where psychologists will fit in that delivery of vaccination schedule. That being said, once we get the vaccine, or if we elect to get the vaccine, I shouldn't treat it like a foregone conclusion. If we do elect to be vaccinated, I've sort of joked, it's not our time to run through the streets proclaiming ourselves immortal. We are still advised to be beholden to all those same good safety measures that the American Psychological Association and the American Insurance Trust have been advising us all along. So the trust has given us a really wonderfully detailed checklist regarding, things like social distancing, the use of masks, temperature checks, how we can be thoughtful, what we can disclose to clients, what we can ask them to disclose to us. And I think this still remains really important in the context of vaccination. If we do elect to be vaccinated, that's something that we're going to have to continue to keep in our practices. It's not a get out of jail free card.
I very much agree with what you're saying. And I think that's something that, a lot of people have been very much looking forward to and, thinking, oh, we can then relax some of these public health recommendations. And in fact, that really isn't the case. We should be still being very vigilant about how this is all playing out and rolling out as well.
For me, the most salient one is the masks, because to do therapy, with a mask on one's face really, prohibits a lot in terms of our facial expression, so I do think there will continue to be a strong role for telehealth, while the public is, receiving vaccinations and while we examine the impacts on transmission rates in the public. I think that we want to continue to maintain these things in our informed consent protocols, ensuring that we are letting folks know what benchmark our expectations and letting them know what our practices are to maintain their safety as well.
I'm thinking, Sarah, just like we all pivoted and had to learn how to emote over Zoom, we may have this same practice with masks and learning how to emote with the top part of our
eyes, Margot. Yes. I think this is going to be a process for many of us. And I think, a question that has come up again, and I would probably look to my colleagues at the Risk Management Roundtable, which is another of our wonderful webinar series that often addresses themes of telehealth, not exclusively, but are among the themes they address. Whether or not people can be required to receive their COVID vaccine in order to engage in psychological practice is a question that has come up not uncommonly in consultation for me anyway in the last few months. And on this, I will give a strong, I don't know, it seems that there is mixed opinion on this, particularly with private at-will employers feeling in some states that they do have the right to do it. Certain hospital systems, I know here where I live in Washington, have opined that they would have the right to do it. Others have, strongly opined that they do not have the right to do it. So again, I think that this is a circumstance where we're really going to need to be monitoring what's happening in our jurisdiction, our employment environment, and if we are the employer, seeking that appropriate counsel, as to what is appropriate to ask of our staff, what is not appropriate, what we are permitted to, and what we are not permitted to. But this is really going to be just an ever-changing public health environment, as it has been for the last 10 months. So that's not news, but I think particularly in the context of vaccination, it brings a lot of solutions, but also, new considerations for us to be really cognizant of as we move forward.
I think it's a really important point that, as a psychologist, if you're the employee, that's a whole context that may be very different if you are also an employer or
Yes.
aside if you're an employer. And it may be very different as well in terms of how people are thinking about just their clinical practice, and, you know, not even in the employment context, but even in the practice context of, can I ask patients if they've been vaccinated, or do I disclose that, or can I require that? And so I know we've had a little bit of conversation about that, and I'm sure it falls in that same category of not really sure where this is going to fall.
And I think it's going to be very interesting. And I say this just anecdotally, I'm not opining as to what we should do, but I think it is going to hit this intersectionality of people's personal beliefs, because I think COVID is one of those circumstances people tend to have opinions on, you know, their personal beliefs, and then, you know, what we are legally permitted or required to do. And so I think it's going to be one of those intersectional spaces where we're going to have to both hold our own ethics as professionals, but then also be receiving appropriate counsel. And then it seems like a worthy investment.
And we haven't really talked about this prior to this, but as we're talking, I'm thinking this is probably even true for asking if, in terms of illness or having had COVID, or kind of, you know, there's a process to that, just like we might on intake forms for other communicable diseases. But I think that's going to be a very delicate question coming along and down the pike in terms of this intersection with practice and opening the doors again, and how that may all transpire.
I know I'm really going to be looking to those return to work guidelines that the trust provided, because I think they were really helpful as I thought about my own readiness, you know, to return to more in-person care and really shift that percentage, you know, off of telehealth. Although again, you know, as we've stated in previous chats, I think we're going to see that telehealth maintains a foothold even after, knock on wood, you know, the vaccines are effective and we start to see the type of, you know, large scale immunities that permit a resumption of more usual day-to-day life. I do, you know, it's my longstanding opinion that we will still have a strong contingent of clients and providers who will continue to prefer the provision of telehealth, even in the context of a post-vaccination era.
Yeah, I think that's a great point. And the pandemic has been a giant disruptor in terms of typical practice across all healthcare. And I really think coming out on the other side, we are going to see some tremendous progress in terms of opportunities for patients that may not otherwise have had access to care or expertise, or even as providers to have more access to those that can guide us in a great way in terms of what our practice is rolling out and what we're doing.
It's well said. Well, it's a new year.
It is a new year.
And you know that I'm okay with it being a new year. I'm okay to say farewell to 2020. You know, and always around this time of year, many of us, and perhaps that's why, you know, we have a lot of folks joining us today, many of us look to our practice, and perhaps this is when we benchmark consideration of renewing some of our documentation or some of our best practices, or really being thoughtful about the business year ahead for us. And so, you know, particularly in the current context, I was hoping to get some of your thoughts regarding how we can well prepare our practices for the year ahead, particularly thinking about those of us who now have a stronger contingent of telepsychological practice.
This is an excellent question. You know, New Year's resolutions, all those kinds of things always inspire a lot of gym goers, but maybe inspire a lot of business owners, practice owners to really review and reconsider what their paperwork, their you know, payments and fee schedules are. And really interestingly, we have a lot of new changes that are coming about, both legal and also coding changes in terms of how things go at the turn of the year. Typically, these are things we may have some reasonable time to consider in past. I think this is the kind of year where we've already been kind of helter-skelter and running on fast steam, and we're rolling right along into a new year and maybe not considering some of those same things. We did a lot of, dare I say, paperwork or policy updates for our practice through the year, and it still is a really good time to review your local jurisdictions, review your licensing laws in all the states or jurisdictions that you're licensed. Because oftentimes January 1 is a time frame where new things roll out despite governor's executive orders, despite federal legal requirements. There also are often new Medicare, Medicaid things that are transitioning at the first of the year. So it really is an awesome time to review those. It is, only January 11th. So this is super, super new in the year. And so there's not a lot of information necessarily available readily right now. However, you want to have that on the horizon as part of your review process. You want to be thinking about what might be coming, or if there's changes in fee schedules, so that you can update your records, update your paperwork, maybe set a goal as the end of January as something to make sure all of that's reviewed, revised, make sure you've reviewed your HIPAA policies, compliance, securities, all of those, so that you can also then refresh what you're putting out there in your web space and making sure those are aligned and updated as well. There's a whole other piece that transitions at the new year, because we've just come through the sign up time for our own insurance policies. Patients may have changed policies and maybe updated their numbers, or they had a different plan, that kind of a group policy change. So you're always going to want to refresh that at the beginning of the year and make sure when you're visiting with folks, if their policies are still the same ones, great time to do that. And I think finally, really my recommendation would be with this kind of the new year, the new process, is just really kind of taking a step-by-step walk through how your practice is flowing, to see if there's any other efficiencies or hiccups or barriers that might be in the way that you want to really shore up or change up. Because if you do that at the beginning of the year, it makes it a whole lot easier kind of throughout the year. So if you're going to transition, it's a great time to transition to something new.
That's so well said. I mean, this last year has had such unprecedented amounts of change from a regulatory standpoint, from a practical standpoint. My informed consent is much more complex than it used to be, with many more sort of points that apprise people of varying and fluctuating, particularly if we're engaging in any sort of interjurisdictional practice that has been facilitated, through some of these temporary mandates. So I think it's a really valuable reminder that it's always a good practice, and maybe extra, after this year that has just held so much change.
And I think too, reviewing, this is a great time to kind of set some new things in motion, or new goals, or if you are going to make some changes in terms of your schedule, really it's an expected time for some changes like that. And so it's an easy time to kind of incorporate that into your practice and your scheduling. So I know I'm trying to keep up with all of the questions coming in.
Great ones, yes.
Yeah. So have you seen any that?
I've been sneaking peeks at them, so I'm not over here texting.
Awesome.
So let's see. I thought this was kind of an interesting question from both, I guess, a regulation standpoint, but then also just, professional boundaries. I have been asked by a hospital administrator where I work to do an in-service via Zoom on the psychological effects of COVID on healthcare workers, social workers, RNs, LVNs, etc. I will not be paid for it. Do I need to have a signed informed consent for each participant? And if so, is there a template for that?
So it was a workshop?
It's a workshop, it sounds like, that is going to deliver some content about, let me say the exact words, the psychological effects on COVID healthcare work, the psychological effects of COVID on healthcare workers. I'll give you my 2 cents on it, because I had, an extra 5 seconds to read it and think about it. And, let me know what you think, Margot. I mean, my thought would be, it depends. Generally speaking, I mean, the payment aspect to me would not be as salient, because whether or not we are paid for psychological services, we are as psychologists still required, to adhere to, informed consent and safety protocols and so on and so forth when we are delivering psychological services. In this instance, however, if it were a lecture circumstance where it truly just was educational, much as folks are coming to this webinar today, and we're going to give them some information inclusive of the health impacts of COVID on healthcare workers, psychologists. In that circumstance, it is my understanding that informed consent would not be required. If, however, we were doing a deeply interactive workshop wherein we were capturing background information, delivering a psychotherapeutic intervention in the context of the time together, capturing assessment information, then I would scratch my head a bit more, and I would start to wonder if indeed, that then we'd start to cross over into a threshold where we're delivering psychological services, to another person and therefore changing that relationship. That's my 2 cents. I'm curious, what do you think, Margot?
Yeah, the reason I had asked if it was workshop, because I kind of think, well, for workshop, I wouldn't typically expect an informed consent form if it's really to provide these folks with tools that they can actually use themselves. And we're going to be practicing some in-session types of strategies. That does, to me, kind of tip the scale to maybe more of a clinical engagement or a group process that might certainly be of benefit. And I think in that case, then I would probably think of it more as an informed consent. But I guess I might clarify with the group that is wanting the service exactly kind of what they have in mind. And if this is for CE for their providers within the hospital setting, then I might err on the side of this being an educational session and not maybe have as individually engaging kinds of things, versus if this is really a staff strategy / staff intervention, then I would think of it more in that informed consent and clinical service capacity.
That's well said. And I think we can be thoughtful about the content we include, to help guide that, to ensure that we're staying within the boundaries. We have another one that's a little more clinically oriented. Please address telephone sessions for allowing us to provide services to our geriatric patients who are unable to use video telehealth sessions. And, I will note that this is a theme we cover more exhaustively in prior tele chats. If this is a great telehealth community chats, just cut the slang that Margot and I use when we talk about. So if you want to do a deeper dive, that is available. But briefly, I will mention that telehealth, does include telephonic visits. So if for whatever reason, video conferencing is not a good match for the client, that is absolutely an option. The thing I like to mention is that many insurers reimburse at lower rates, and there are different CPT codes used for those telephonic visits versus the video conferencing visits, which typically enjoy higher rates of reimbursement. So, that's something you just want to be thoughtful about when thinking about your own reimbursement, is that, for whatever reason, they will always favor typically the higher rate of reimbursement for the video conferencing calls.
And I think this is something to maybe pay real close attention to in this month, because I would anticipate that there are some changes potentially coming in terms of that coding. And so we need to take a bit more of a deep dive in, and this might be something also that rolls out through one of the risk management webinars that are coming up. But I think looking at the coding and seeing if there are some changes coming with that, whether or not it's kind of considered an equal reimbursement process might be different, but there may be some other codes coming that will be helpful for us actually in delivering telecare.
Our current context has been an accelerant for, so many considerations of how we administer telehealth.
Yeah.
Well, I'm looking at the time, it's almost 2:30. And so I was gonna move on to some of our previously submitted questions and information. I think we received some questions in the prior months about the overlay and the role of telehealth when thinking about diversity, equity, inclusion, and how telehealth can be an agent of change. And I think, and this is something we've touched on briefly previously, but I'm excited to give it a little bit more depth and breadth. As you know, Margo, this is something I'm very passionate about, the idea that telehealth could be a tool to advance this type of social change, and thinking very concretely about how we could do that. I think that when you think about the opportunity for clients to pursue clinical relationships with therapists that share their background, be it race or ethnicity, be it gender, be it sexual orientation, be it gender identity, I think there is this tremendous opportunity across the spectrum of how we self-identify, but particularly when thinking about people of color seeking therapists who are themselves people of color. Oftentimes we might live in a community that has fewer of those resources, and through telehealth we can have access to more resource-rich environments to have that type of clinical match that is meaningful. Similarly, for clinicians of color, that for whom it might be meaningful to be working with clients who share a similar background, and that's something they want to invest in. If we are making sure that folks have opportunities to be trained in telehealth, that they can expand their practices in that way, I think there's this really nice marriage of themes there. And really for clinicians of color who have training in themes of cultural competence, I want to really encourage anyone who has not yet seen the We Hold These Truths webinar series that the Trust is offering to do so. It's truly excellent, really thought-provoking, so well done. And I think it's a great opportunity of access to a training that perhaps, I didn't know these colleagues before, seeing the videos, and I'm delighted to now. And I think that it is a tremendous opportunity for us to be thinking about consultation, to be thinking about continuing education, and not volunteerism, not asking someone to just, volunteer and talk about this, having recently shared they were voluntold to do an in-service at work. But, to elevate our colleagues who have this specialty training, to their sort of appropriate place of erudition, as they share this information, I think is a good opportunity as well.
I can't agree more. I think it really is, like I had said before, a disruption in a very positive way in our healthcare provision community. I also think about how Zooming and HIPAA compliant platforms and the opportunities that we have now to even reach out to our colleagues for consultation in a manner that we really haven't had that ability to kind of utilize historically. And I think another piece of this is sometimes there are very closed communities where folks feel surrounded by people they know, and they don't want to necessarily seek care in that community. And this really is a way for them to reach beyond that kind of geographic or maybe rural landscape to be able to access care that they wouldn't otherwise, have that access to. However, I think we still have barriers. We still have digital natives. We still have, folks that don't even have access sometimes to, internet that can support a video feed or a consistent feed. I live in a land where cell service is not consistent. Right. I realize that's like a novel thing for some folks, but we don't have 5G where I live. So there's still challenges for some of the folks who need services the most, and there are still those barriers. And I think we have to be very cognizant of that as well.
Yeah. I think we can't talk about this theme without acknowledging income and opportunity disparities, that occur and particularly disproportionately impact communities of color. And in this way, I get all excited about telehealth because I always get all excited about telehealth, but we need to remain thoughtful about the provision of those resources that facilitate telehealth, because without those, it's just a nice idea and incredibly impractical.
Yeah. And I think we have to think about, some other cultural components to this in terms of, the question earlier about, nursing care facilities, and that, telephone seems to be more of an acceptable or possible provision for care in those communities. I think also one other aspect I would mention here kind of goes back to the paperwork piece, and that is, as you're reviewing your paperwork, now that you've attended and been aware of a lot more of the diversity and inclusion factors that we've been talking about, make sure your paperwork is up to speed in terms of your terminology, the language you use, the ways that you're asking for demographic and introductory information from your clients, because that can really be a clue that you've done your homework as a practitioner and have a well-rounded perspective in terms of how you are providing care.
I believe APA style now advises the use of the singular pronoun there, which is, a big shift in my lifetime in terms of grammatically how to approach something. But then additionally, I think belies, a recognition and representation, of gender identity that seems really relevant. I think all of these things, as we want to make sure that, our as you say, our documentation, includes the type of inclusion that we want to have show up in our clinical practice.
Right. And how we want to be perceived, right?
It matters. Yeah,
exactly. I think we can't, I guess, chat enough about these topics and kind of the intersection of how they all come together. That, practice is not this kind of singular focused vision. We have to think about all of these areas and how we blend them all together. And the new year is a great time to really filter that into all of the analyses you're doing in your practice in terms of the paperwork from, the front door or the video conferencing door, all the way through to, kind of who you're serving and communities that you may want to reach out to that you haven't thought to do before, but now might have an ability to do that with telepractice.
Well, we continue to get a lot of good questions. Should we pause and take another one?
Sure.
Okay. As we look at telehealth as an ongoing treatment modality after the quarantine requirements are eased, what types of information are available to provide the public about the pros and cons of this option?
Oh.
That's a good question.
That is a really thoughtful question, because right now we're just like, no, let's just do it. This is how it'll be. And yeah, I think as we've kind of filtered and sifted and sorted out this year in terms of just thinking about healthcare in general, there's certainly some things that seem to lend themselves well to telepractice and some things that don't. I can think of my neuropsychology colleagues and my assessment colleagues that are trying to pivot. But I think we'll probably really appreciate getting back into a three-dimensional space with their patients. That's certainly one area. I think there's a lot of things to consider from both your own perspective of if this is something you want to continue to do as a provider, and to whom and to which patients. And then from a patient standpoint, what kinds of patients make the most sense to continue on in teletherapy processes or to transition back? And sometimes that might be the patient's preference. Sometimes that might be a boundary preference or an access to care preference or an ease of kind of having a scheduling preference. And it may be you as the provider, your preference in the depth or seriousness or breadth of kind of how you felt this time has gone with, the video conferencing, and whether or not that some of those topics or areas or skill sets are things that you want to continue. A whole host of other folks, I think, have found that maybe there's a way that video conferencing can play a role with the same patient, but you might do in practice in the office and video to kind of help with things that you're working on. So I think it really is going to bring a lot of different considerations moving forward. How about you, Sarah?
I think that's so well said. The services we provide, the goodness of fit, with the telehealth modality, the populations we serve, and sort of their ability to get on board, with this modality, or their desire to do so, or, this has been unprecedented, wherein patient preference was not king in this determination. The readiness of appropriate space, both on the clinician and client side, the availability of appropriate technology. Right now, we're making it go. I've seen clients in their bathrooms, with terrible internet connections, and we are just doing our best, and when in-person care is, solidly safe, that is an obvious circumstance. Or as you mentioned, the clinical concern. I think the first clients I'm going to be having back in the office are those clients who experience domestic violence. This is an unsafe modality for them in some ways. But additionally, I'll mention that the trust has a wonderful informed consent document for telepsychology, and perhaps we could get that pasted in the chat if it hasn't been already. That this document does, I think, a nice job of outlining some of those additional considerations, pros and cons, things like, the internet inherently, is never going to be entirely secure. We just know that. We use technology products that do their best to safeguard our information, but fundamentally, the internet, has vulnerabilities. And so when we put information on the internet, we assume those vulnerabilities. So I think I would refer folks, if they were looking for a document also to review, to take a look at that document, because I do think it does a nice job summarizing some of that.
Yeah, I think this isn't necessarily something where you have to reinvent the wheel, but we've got a lot of resources out now through this past year that really can help you make some good decisions about moving forward with that, and help your patients make good decisions in terms of access to their care. Sarah, I've seen a number of questions that relate to jurisdictions, and we always get these questions. It might be worth a really quick review that we've talked in great detail in some of our past chats about how best to make decisions about where you're located, where your patient's located, crossing state lines, all of those kinds of things. Not to really distill things down, but these are complicated questions, and inevitably we have, and I applaud folks for asking, because it really is important to ask these questions, because I will also say there's probably many more who aren't asking this question, and they should be. But if you have a question about, I'm in this state and I want to go to that state, or my patient went to that state, can I continue care? Any version of that, I'm crossing a state line, or my patient's crossing a state line, and now I want to continue care. It boils down to knowing what the law is where you're licensed, and whether or not interjurisdictional practice is acceptable, and what the requirements are, and the other jurisdiction of whatever jurisdiction that is, what those practice requirements and guidelines are, and whether or not that's acceptable. And short of you yourself evaluating and researching that, it's really difficult to give a very specific answer. So you need to know your laws, you need to know the laws of the other jurisdiction, and you also need to look at, if this is a third-party carrier, insurance carrier paying for the service, you also need to find out about what those requirements are, because the laws may allow it, but you may not be able to seek reimbursement for it, and that might be not a great surprise to have after you've gone ahead and done service. So I think
I'll also add a plug here for the SIPAC e-passport program, which now we're able to apply for. I believe it has 17 compact states. Is that right?
Wow, we're growing every month, actually.
Right on this, that there are currently 17 member compact states, which fundamentally this means that someone who holds the SIPAC e-passport would have regulated, articulated permissions to practice interjurisdictionally among those member states, provided that you live and work in a compact state. So unfortunately, Washington is not in the compact. So I can't just get one tomorrow and start, practicing in all the compact states. I have to actually be in one of the compact states. Believe me, I've tried.
And just to follow up to that, somebody's asked about should interjurisdictional practice be addressed in informed consent? And absolutely. And it is and should be always addressed when you visit, no matter when you're visiting with somebody that you're not in the same office. You do need to ask what jurisdiction they're in. And be able to verify where they are and know that so that you know what's going on with your practice. So those certainly can be included into your informed consent and questions that you might just always be asking when you're connecting in video or telephonically.
I have a longer question, shall I? Or shall we move on and talk a little bit about some of those disciplinary concerns?
That is a really short answer. So if we want to do another question and then I can do a short answer, that would be.
All right. This is a longer one. Some insurance plans have allowed the waivers for telehealth platforms to expire, which means that for telehealth services to be reimbursable, they must either be offered in person or you must use the insurance dictated platforms. This is not something I'd heard that much about previously. My team members and I are practicing in Arizona, which is currently the COVID hotspot of the world. Yet it appears that there are many barriers to successfully using these insurance telehealth platforms with already established and ongoing clients. Any guidance of sharing a personal experience is very welcome. Thanks in advance.
Well, this is really interesting because the way the question's written, it sounds like the insurance company is actually providing the video conferencing platform.
I've never heard of that previously. Now, I will say I've heard of insurance companies requiring, of making partnerships with large scale telehealth providers. So examples, I'm not endorsing any company, I'm just saying names that are examples, you know, Teladoc, Doc on Demand, American Well, Ginger, you know, Talkspace, you know, these types of things where they've, you know, they've made a partnership and they say, oh, well, if you want telehealth, go talk to our guys over at Talkspace because they've negotiated a much lower rate, you know, with those larger telehealth entities, because the larger companies can scale in such a way that they can afford to really charge a lot less than the average independent practitioner.
So that actually sounds like they're funneling patients away from current providers into that. Okay.
Yeah, that is a known thing happening. I've never heard previously that they're requiring folks to use this specific video conferencing platform. I will pause and acknowledge this is my very highly well-researched answer. That's weird. You know, I haven't, that's an unusual thing because we do have CPT codes that are specific for telehealth that, you know, we can find. I'm going to trickily answer another question within there that you can find on the Center for Medicaid Service, the CMS website, if you ever want to go look at where you could find, you know, those telehealth billing codes, most up to date. That, and they are totally agnostic to video conferencing platforms. So this is I would think something pretty darn idiosyncratic to these insurers. I mean, my 2 cents would be to, in light of the circumstances, to call that insurer and ask, you know, simply, I mean, maybe that's naive to think that that would work, you know, but to simply ask for, you know, dispensation on this one because the impracticality and the friction created by using a cumbersome video conferencing platform is non-trivial.
Well, and to me, it raises concerns about who's the covered entity, and you're required to use HIPAA compliant platforms, or at least we recommend that if the requirements are lifted in your jurisdiction. But our recommendation would be to always seek that HIPAA compliant platform, and that BAA would be with you as the provider. So it would seem to me it would get very complicated if there's like now an insurance company that is involved in that kind of process. So I'm not sure, maybe some more information about that. And I'd encourage the folks that wrote that question in, if they could provide us a little bit more information at the telehealth community chat email, that would be awesome. We'll do a little more research into that.
That'll be on our last slide if you don't have it already.
Right. So we did have a lot of questions over time. So frequently asked question about, are there any licensing board complaint actions related to telehealth, telepractice that would either inform or I suspect maybe help us know a little bit more about, well, how concerned should we really be about interjurisdictional issues or telehealth issues in terms of what's happening from the licensing board side. And I've done some digging. There's not a lot to find, but I will say in the worlds of veterinary medicine and pharmacy, we have seen historically some interjurisdictional challenges, complaints, and issues that have come and percolated through the legal process related to complaints. We haven't seen a whole lot in psychology, and I suspect some of that is because we're just, from a consumer side, we're really happy to have services and might not necessarily have as much concern from a consumer standpoint as to where you're located, or if there's an interjurisdictional issue. That's on us as the providers, and to be very vigilant and practice within the scope of our license. But we have seen some litigation of that in other practices or other professions. So it's something that I suspect is probably down the road. But the most, reaching out through the licensing world and community, we haven't seen a lot of complaints necessarily coming in with regard to telehealth practice. That doesn't mean that there hasn't been complaints about care delivered in that way. It just hasn't been focused on the kind of the video conferencing or an interjurisdictional issue.
That had been my impression as well. It seemed to me that quite often when I've heard of complaints related to telehealth, the complaint was about something that happened over a telehealth session. It wasn't about the telehealth, and oftentimes it was something, that would fall into one of the other areas of ethical concerns. I will also acknowledge, Margot, the cases you bring to consult with me on are my favorite. You always have the best ones. But really, it's circumstances in which folks are, engaging in problematic practice. And yes, it happened over telehealth, but that's not the central point.
Right. And so, oh, go ahead.
I wanted to acknowledge that, like, when we're thinking about shoring up from a risk management standpoint, I'll just hit the oldies but goodies quickly and say that, we use HIPAA compliant video conferencing technology. When we use video conferencing, we use messaging with our clients that is HIPAA compliant. Preferably, I tend to like things that are integrated into our EHR if we use one. We don't use things like text on our phone or our Gmail to communicate with clients if we really want to shore up that risk. We document things. We have a good informed consent policy that addresses telehealth risks and benefits. We have an emergency plan. I think it's that investment, that first of the year documentation investment you were talking about earlier, can really pay dividends in shoring up our risk management. These are the, sad gray rain cloud worry wart considerations I would share with my colleagues. And as you mentioned so well and articulately here, the actual rate of complaints related to these themes seems to be relatively low.
I think overall, we want to be vigilant. We want to be aware. We want to, do our due diligence in terms of how we're practicing and really document, right? How our sessions are. And if we have a consistent and systematic process that we do that helps protect us on our side in terms of just our practice style and how we're engaging with our patients. So
one of the folks on the webinar who's watching today pointed out, and as well they should, and I should be ashamed because this is the world I come from, that the VA does use its own portal. So the VA, when they serve, I believe it was previously Cisco Jabber Video, I don't know what it is these days, but the VA does have its own idiosyncratic video conferencing portal that they use. So here we are saying it's not as common, but in fact, the largest national provider of telehealth does in fact have its own video conferencing portal you can use, which also, to my knowledge, has low rates of disciplinary concerns.
Awesome. Also, in scrolling through some of the Q&A, we are corrected. There's 16 jurisdictions in the SIPAC.
17.
Maybe there is one missed it. There's probably, that one's coming soon.
Always have optimism for one that didn't happen yet.
Exactly. But super exciting. That's been a long time in the journey, and now it's really taking shape. So definitely you can hop over to ASPPB to find out more if you're curious about how to get involved with that, or if your jurisdiction is within the SIPAC. So I'm just so excited. We have so many questions coming in.
We're getting a lot of comments from people saying that their insurers also have required them to use a specific platform. And it sounds like from the naming conventions that are used that they're potentially proprietary to the region or maybe even the insurer. I don't know. So this is something, please, send us an email at the email address you'll see at the end of our slides today. And we're going to go do some homework, because I have to say, this is something that I've not heard that much about, and I'm really eager to learn about. And we'll report back in our next chat what we find.
And if you can give us specific details, like what the insurance company is and where you're located, that'll be really helpful for us to kind of fine tune and pinpoint a little bit more to help us understand.
If you put it in the chat, we have it. We save all of these and we reference them for the chats to come.
Yes, yes. Well, Sarah, we are approaching the top of the hour again. I don't know how, it's just like it's rapidly going by faster and faster. So is there any other things that you have seen in the chat or that has come to mind that we haven't crossed off our discussion list for today?
Well, I think that as always, people aptly note some of the challenges idiosyncratic to specific disciplines within psychology. So, neuropsychological assessment, testing, those folks who really benefit from that hands-on environment. And I think a consistent question we receive at these telehealth community chats is, well, what does one do? If you have a testing-based practice wherein the tools that we use are really normed to in-person administration, and how are we making that jump? And the thing I'll say is that, well, I guess we should take heart for two reasons. One, with the availability of a vaccination, I hold hope that things return to a modicum of normal, in the months to come. But additionally, I'll share that a thing that I really see strongly trending in not only new companies emerging, but in established companies that offer metrics for psychological assessment is a strong orientation towards normed self-report psychological measures. So I'm thinking particularly, there's a company that just launched this just the end of last year that offers a net. They had offered the net skid, which was a skid that was administered over the internet, a clinician administered skid. And I think they went on then to offer, I think it's called the Telesage, which is a smaller abbreviated self-report, version of a skid. Now that's not the same as doing a neuropsychological battery, of course, but I just pick on them as an example. I think what they're doing is really neat. I think we're seeing more and more companies really being responsive to this problem. And now we've had 10 months since this problem emerged. So I'm starting to see some products come to market that hopefully will start to bring some solutions to folk who are stuck in this bind.
We're not as fast as the vaccine world of getting things to market, but
we're not that fast. We're not Pfizer.
We have pivoted this year. So, I have so much enjoyed our time together. I enjoy these questions. We've got a lot of really awesome questions to build on for our next chat. Yes, they are all recorded, and you can find those through the Trust Risk Management websites, and log in and listen, and enjoy hearing more in-depth conversations about some of the topics we kind of skimmed over today.